Our next speaker is Galen Joseph. Dr. Joseph is an associate professor in the Department of Anthropology, History, and Social Medicine at the University of California, San Francisco. Her research examines the evolving social and ethical implications of genomic medicine and the sociocultural and institutional dimensions of inequities in cancer care. Dr. Joseph?
Hello, everyone. Thanks so much for inviting me to speak today. I'm going to talk about cancer genetics, which we've heard little bits and pieces about throughout the day. I want to start with this question of what do we actually mean when we say cancer genetics, because I think it means a lot of different things, and we have a lot of different terminology that we use. So we're hearing the terms personalized medicine and precision medicine a lot. A new precision cancer building opened up at my university just a few weeks ago, and I hear about it every morning when I listen to NPR in the advertisements. It's kind of remarkable how much it's being advertised. Genomics as opposed to genetics, computational medicine. The last time I was here at the National Institutes, National Academies, was for a computational medicine conference. And in any case, what we're seeing is that genetics in its various forms is influencing cancer across the continuum. So in prevention, for example, you're seeing risk assessment using polygenic risk scores, or PRS. You're also seeing that in cardiovascular care. It's still at the very beginnings, but it is starting to be used, and it's starting to be used by direct-to-consumer companies that provide genetic testing. We're also seeing what we've been seeing since the discovery of the BRCA genes, the BRCA genes, 20 plus years ago, is germline testing for hereditary cancer and genetic counseling, which I'll be talking about a lot more during this talk. And then, of course, targeted treatments using molecular tumor testing. So there are great challenges to integrating genetics across all of these domains. One of the big challenges is the underrepresentation in genomic databases of diverse populations. This is a huge barrier to care and has created, well, let me give you a couple of examples of how this plays out. So, for example, in genome-wide association studies have been done for over a decade, couple of decades probably, and the majority of people who've participated in them worldwide are European of European descent, the vast majority. That's changed only a little bit. It's only diversified a little bit because countries like China have started doing a lot more of these studies. As a result, the use of these polygenic risk scores to assess risk and describe what kind of screening people should have, those don't work as well for people of color in this country. And yet, so for example, actually one company, Myriad Genetics, is only giving results for people of European descent for those so far. So another big problem is the uncertainty of hereditary cancer test results. So you get a lot more variance of uncertain significance for populations that aren't in these databases, just simply because we haven't seen all the variation yet. So there's really been in the last several years a groundswell of attention to diversifying genomic research. And you see it in the All of Us research program, which probably most people have heard about, but also other NIH initiatives like the Clinical Sequencing Evidence Generating Research Consortium, or CSER-2, the second round of that funding, had a requirement that at least 60% of the populations included at all of the sites be from underrepresented groups. We also know from research that genomic literacy, not just health literacy, is extremely low in this country. And that goes not just for patients, but for many, many providers who are now being confronted with genetic test results that either their patients bring in or that their colleagues send them. So we know that we need to improve genomic literacy in order to realize the promise of genomic medicine. And there are huge promises, which we'll see. We've been hearing those for a very long time. One of the new things that, and maybe it's really not new about genomics and genetics, is that there's an exponential amount of complexity and uncertainty. So we've talked a fair amount about uncertainty throughout the day. I think you throw in a little genetic test and things become even more complicated and harder to explain if people don't remember their high school biology class or maybe never had a high school biology class. So the other thing is that it's not just people with low health literacy or even low genomic literacy, but it's really relevant for the general population, both because the very few people, only about 12% of U.S. adults are fully literate in healthcare. But physicians typically overestimate patients' literacy levels, and I would say that goes for other healthcare providers, and also for numeracy, which becomes incredibly important in genomics because so much of the information is probabilistic and estimated risks. Health information and, of course, the healthcare system can be very difficult to navigate even for highly skilled people, and a new diagnosis is stressful. We've heard this multiple times today. But really, communication is the most common procedure in medicine. We kind of forget that because it's just part of the air that we breathe. But if we think about it actually as a procedure, then maybe we would be able to give more attention, better integration into training from the ground up that would help. So several years ago, I'm going to talk about two studies, this one briefly and then the one that it led to. But several years ago, I wanted to think about how all of these issues of health literacy were playing out in genetics, in genetic counseling in particular, in public hospitals. Zuckerberg San Francisco General is one of the first hospitals, public hospitals across the country that offered genetic counseling to their patients who are primarily either on Medicaid or other public insurance or uninsured. And I wanted to see how did these communication challenges play out in this complex discussion with patients who are more likely to be of low health literacy. And what can we do about it? And what I found was that genetic counselors who, in their title, counseling, are trained in communication. So they think of themselves as a profession that is good at communicating. But what I found was with this population, the patients really experience the interaction as providing way too much information that was given with very complex terminology, was conceptually difficult, and was perceived often as not relevant to the patient, and that counselors unintentionally inhibited a dialogue and engagement on the part of the patient by overloading them with all of this information that they didn't really know how to manage. And then the really important information for the patients, which was what do I do next, a lot of that was a little bit vague in terms of what screening or prevention options the patients should pursue. So I took all of these findings and thought about and looked at the literature on what evidence is there for how to communicate effectively. And most of this research was done in primary care settings, so not in the genetics setting. And so a lot of it needed to get massaged and applied. But what we did then was develop an intervention based on these principles of effective communication with patients of lower health literacy, that it's the clinician's responsibility to make that communication effective, to think about the universal precaution principle, that everyone can benefit from plain language, that patient comprehension can and should be verified. A lot of the feedback that I got from counselors when I presented this work was, oh my goodness, it's so incredible to actually hear what patients have to say about what they understand. I kind of knew I wasn't getting through, but I wasn't quite sure what to do. So, and then finally, that really adapting to address these different literacy levels and numeracy levels requires commitment, flexibility, and most of all, practice. So we took all of this and developed a training for the counselors that had participated in the previous study, and spent about 4.5 hours with them and talked to them about ways to potentially recognize limited literacy, although you don't always know, and which is why they should think about the universal precaution principle. How to use plain language, what plain language actually would work in genetics and in genetic counseling. How to focus on key messages and avoid providing too much information. Using risk communication tools that have been shown to actually work better, like frequencies and absolute risks, not like in the cartoon here. Not having your statistician drop in to explain your situation. And then really trying to get them to assess comprehension. So use teachback with their patients. And then we also talked about working with limited English proficient patients and working with interpreters. And we ended up doing a whole sub-study with interpreters because that raised a whole bunch of other issues. So that research, I was very fortunate to be invited to participate in the CHARM study when it was being developed as a grant proposal for the CSER 2 consortium. And this study basically is trying to increase access to genetic counseling, or to genetic testing, I should say, for hereditary cancer in underserved populations. And underserved is defined in different ways by all the CSER sites. At our site, we're defining it as low income, low literacy, and underrepresented or minority populations. So we're recruiting patients aged 18 to 49. They are primarily healthy patients. They may have had a personal history of cancer, but we're assessing their family and personal history of cancer, but have a wide admission policy for people who don't know their family history, who were adopted, who have small families, and therefore don't. The algorithm doesn't really work for them. So we have actually quite a few people in the study who wouldn't normally qualify for genetic testing. And we're recruiting them at Kaiser Permanente Northwest, where one of the PIs is based, Katrina Goddard. And so that's in the Portland area, and then at Denver Health, which is a federally qualified health system. And we're doing everything in English and Spanish. And this is kind of an overview of the study. And the part where I come in is that the participants are randomized after they get a clinical exome sequence. They're randomized to traditional counseling or a modified counseling based on the intervention and training that we developed at UCSF. And the approach to communication throughout CHARM is really, I've been so impressed. This is a team of about 50 people, and I have not been involved in many aspects of the study because it's enormous. But all of the materials have been designed for accessibility for people of limited health and genomic literacy, and with stakeholder input, importantly, and stakeholders who are English and Spanish speakers. So we had two separate processes for stakeholders. in both languages. And everything has been translated, and not only translated, but really culturally adapted into Spanish. And that process has gone on simultaneous with the development of the materials, so it's actually influenced how the English materials are presented. So it's a two-way process. So it's definitely not an afterthought, which is something that I've seen in many studies. And then the consent process is web-based, but there's an option there are a lot of illustrations, there's an option for audio. So for people who aren't good readers or who just prefer to listen to sections, critical sections of the consent, they can do that as well. And then to follow up on the interpreter work that I did in the previous study, we're also training medical interpreters on exome sequencing, and we're going to do a study of if and how that works. We'll see how good the training is. So for the results disclosure, so the participants send in a saliva sample. They get, because this is an exome, a clinical exome, they not only get cancer results for 39 genes, they're also getting 79 medically actionable genes. So that includes the ACMG recommended genes and a few others. And then they're also getting carrier results for 14 genes. And then the genetic counselors return the results by phone. So part of what's really interesting is that there's not a pretest counseling appointment. So here, the results appointment includes some elements of pretest counseling, like collecting family history, verifying family history that was collected on the risk assessment, but then primarily it's focused on delivering the results. So the traditional care, and it was a very interesting process of adapting the modified approach from what we had done previously, which was in a context where we were focused more on the pretest counseling, but also trying to really define what do we mean when we say traditional or usual care genetic counseling. You might say there are as many forms of that as there are genetic counselors. But in any case, what we expect is that it will be more conceptually and linguistically complex, more emphasis on education and information delivery, in contrast to the modified, which will be more simplified with more of a focus on communication and the psychosocial counseling. I'm speeding up here because I see my time is running out. We also did a much more in-depth counselor training. So instead of spending 4.5 hours, we spent an hour on each of these sessions, plus a few sessions interspersed between them to review and go over observations that the modified, that the counselors being trained had done with their peers in clinical settings, just to help them think about what am I needing to do differently. And then since we started about 9 months ago, we've also been having case conferences most every week to review cases, share methods, for the counselors to talk to each other, and for us to review some of the training that we did. So we have lots of data that we're collecting in surveys. We're expecting 880 participants overall in the study. So you can see the survey measures. We're also doing qualitative interviews 2 to 3 weeks after they receive their results with 50 participants, and then we'll re-interview 25 of those 6 months later to, in particular, look at things like family communication and follow-up care. But there will also be I won't be involved in it, but there'll be a medical records review through the EHRs at both the sites to look at things like follow-up care and how much utility of services and cost and all of that kind of stuff. We're also recording all 880 of the sessions, so we have a coding scheme that we've developed to ensure fidelity to the modified and traditional. Fingers crossed, otherwise we're in big trouble. And then we also use those audio recordings to tailor and prepare for our qualitative interviews, so we really know what they talked about with the genetic counselors. So a few next steps or topics for discussion beyond this kind of supplemental training. Could this kind of training really be integrated into graduate education for genetic counselors, emphasizing relationship building? As genetics and genomics has grown, genetic counseling training has changed, and people are being inundated with information that now they're excited to share with their patients. The field is changing really rapidly, so all of this, there's a huge churn, and it's not just genetic counselors. Genetics is infiltrating many fields of medicine through direct-to-consumer testing, through just managing the clinical test results in primary care and oncology and other specialties where people are not trained. So anyway, that's the huge CHARM study team. And I thank you all very much. Look forward to the discussion.